I have no disclosures. So splenic flexure mobilization, as Nitin just very elegantly laid out for us, can be done for two purposes: preparation for local resection, so say for a splenic flexure cancer, or for colonic lengthening for a rectal anastomosis, or as was mentioned in a transverse colectomy. Either way, the goal is relocation of the colon and its mesentery of the splenic flexure into the abdominal pelvic cavity. And sometimes I'm called to help in a room where they tell me the flexure's been mobilized. However, just dissection at the white line of Tolt up to the splenic flexure has been done. So by no means is that really splenic flexure mobilization. That whole flexure has to really move into the mid-abdomen and lower abdomen in order to be properly mobilized. As was mentioned, it's definitely challenging and there's a learning curve. I won't review a lot of data. This is, I think, the survey that Dr. Mishra was alluding to. 30 surgeons, all members of European and American laparoscopic societies, surveyed about the difficulty of laparoscopic colon procedures, and for the abdominal procedures, splenic flexure mobilization ranked in the highest, with transverse colectomy requiring splenic flexure mobilization. It's time-consuming. On average, 45 minutes from a NISQIP analysis with retrospective chart review to corroborate it, and may be associated with some minor morbidity. However, I completely agree that when you're prepared to do it, when you have the mindset to do splenic flexure mobilization, as you're looking at your CT scan planning for the pathology parts of the operation, also have a look at the splenic flexure, have a look at the transverse colon redundancy plan, and get an idea about the splenic flexure. I also agree, if you are a selective splenic flexure mobilization, or like some of us who routinely mobilize the splenic flexure for most cases, do it early in the case. Plan, and if you're planning to do splenic flexure mobilization, do it early in the case when you're not tired and your judgment isn't impaired about whether it's required to be done or not. And then it's for splenic flexure mobilization to be appropriately done. There's a lot of interesting anatomic landmarks to know when it's been completely mobilized, and we'll have a look at that. So many ways to mobilize the splenic flexure. I was initially taught a lateral, retrograde, and antegrade mobilization, and I do teach more junior residents in this method. I find a medial mobilization, which one of the next speakers will speak about, to be a bit more efficient in my hands. However, in thin patients and trainees who are comfortable with an open approach, I like starting with a lateral approach. But anyways, we need to know both approaches. So for the retrograde portion, we're going to be talking about detaching the descending colon after it's already been mobilized, the sigmoid colon's been mobilized, from the white line of Tolt. And for the antegrade, we'll be talking about releasing the colon from the greater omentum and entering into the lesser sac. So for preparation, patient positioning is key. For the splenic flexure mobilization part, whether in split leg or in lithotomy, I prefer split leg unless a coloanal or pouch anal anastomosis is performed to limit injury to the perineal nerves. But the legs need to be split, both for access to the anus for later on parts of the procedure, and for allowing the surgeon to stand in between the legs for the uppermost splenic flexure mobilization. The arms need to be tucked, and because we're going to be with right side down, that right arm needs to be really well protected. I've had obese patients with ulnar nerve injury, temporary ulnar nerve injury, because the whole weight of the body is lying on that right hand. So the beginning of the procedure for a retrograde antegrade operation will start in different degrees of Trendelenburg, and as we head towards the spleen, especially in more obese patients, the degree of Trendelenburg can be reduced until we reach the uppermost portion of the dissection, where we are in maximum reverse Trendelenburg. Again, careful to protect the leg and arm on the left side, sorry, so it doesn't get injured. Again, one needs to be cognizant of the changes in cardiorespiratory effects of changing the position from Trendelenburg to reverse Trendelenburg. So the room setup, typically, if we're starting with a lateral mobilization, say of the sigmoid colon, the surgeon is close to the patient's right hip. However, as we proceed to the upper portion of the splenic flexure mobilization, the assistant comes below the surgeon, holding the port. The surgeon is on the right side of the patient, using the two working ports on the right side. And the surgeon can come in between the legs with an assistant port in the left lower quadrant for the uppermost part of the dissection. Another alternative is an epigastric port for the assistant. At this point, the nurse doesn't really like it, but we ask them to get out of the way a little bit, and the monitors need to be changed. All right, so upon entry into the abdomen, a diagnostic laparoscopy is always performed, and ports are placed in the right upper and right lower quadrant. Here is an example of 10 millimeter ports with Babcock's. However, this can definitely be performed with 5 millimeter ports. I prefer to start out with only 2 working ports, especially if I'm teaching trainees, so they can learn to manipulate the bowel themselves. The small bowel has to be moved into the right upper quadrant as the beginning of the procedure. So we'll break down splenic flexure mobilization, retrograde, antegrade into 4 steps: the lateral mobilization of the descending colon, the antegrade transverse colon mobilization, supracolic completion, and this is really chomping at the splenic flexure from both ends, making sure to completely mobilize it. This is probably the hardest step where we put it together. And finally, as an adjunct, the inferior mesenteric vein can be ligated. All right, so for the retrograde descending colon mobilization, again, the patient is in a degree of Trendelenburg, which will be reversed as we get closer to the splenic flexure. The sigmoid colon is mobilized at the white line of Tolt with careful attention to identify the left ureter and move it out of harm's way. So we start with traction here. There's only 2 working ports, one retracting the colon, and then we are peeling the retroperitoneal attachments off the mesentery after the white line of Tolt is incised, and this is done in layers. One of my teachers would always say, you're just peeling layers of an onion, 1 layer at a time. And traction is so important for this portion of the operation, and never hesitate to put in another port if we have to assist the trainee or the surgeon in putting adequate traction. Again, one needs to know their graspers and how to manipulate them best not to injure the colon or its mesentery during this portion of the dissection. It can be done with scissors, hook, ultrasonic device, many different tools, all adequate. So here again, you can see the plane easily, and using energy devices, sometimes you can use them as a grasper with blunt dissection being performed, as well as sharp dissection. And as we're heading over to the spleen here, you see that there's still another layer or 2 to open up. So we move from a caudate to cephalad direction towards the spleen. Again, without really letting go of the colon traction, we move our hand up and down to be able to adequately see where the 2 planes meet. And here we are dissecting gerodas away from the colon mesentery. During this part of the dissection, especially if you were doing it as a colon lengthening procedure, and this part will not be excised, it is so important not to enter into the colon mesentery. And that's why for very thin patients, I find a lateral approach a little easier, because I'm not as worried about entering the mesentery as with a medial approach. So here we are again, trying to just layer by layer peel it off as we head towards the spleen. And you'll see now as we get towards the last attachments of the spleen, we'll start again lower down at the descending colon to release the next layer. And at any point, if it's not efficient, an extra grasper can be placed to retract the colon better. Here we are with doing this next layer of dissection just to release the mesentery of the colon completely from the lateral retroperitoneum. Okay, we'll keep going. So what to be concerned about is it's very easy to be in the incorrect plane during this lateral mobilization. As one of my other teachers taught me, is that you look for these circles, and I always point them out to trainees when you enter into the retroperitoneum. So when we see a circle like this, you know that you're 1 layer too deep and you really got to drop all that tissue down. Again, if you're too superficial, you'll get into the mesentery and injure it. Identify the left ureter and protect it. When you're higher up near the spleen, if you're too deep, we be concerned about injuring the tail of the pancreas. And finally, with all the traction that we're putting on the colon or mesocolon, depending how we're retracting, careful not to injure it. All right, so for the second step, it's the antegrade transverse colon mobilization, and there's 2 ways to do this. One is to enter the lesser sac just below the gastroepiploic vessels, and second is to detach the omentum from the transverse colon, entering into the lesser sac. My preferred approach is option 1 because I find it to be more efficient and can be done with only 2 graspers. However, again, like in surgery, it's always better to know more than one approach. And again, here we are in the reverse trend, most of the time required to be in the reverse Trendelenburg position unless the patient's pretty small. So here the entry is at the midpoint of the gastrocolic ligament, and as we proceed towards the spleen, you'll see that the lesser sac becomes wider and the dissection becomes easier. So with a grasper on the stomach, holding it above the liver, the lesser sac is identified and can be entered either with an energy device or a monopolar cautery. Once a window is created, it is better to have an energy device because you can dissect and transect at the same time. Here, careful attention to identify the gastroepiploics and to stay just beneath them. Also careful to protect the back of the stomach. The tricky part is we have to flip our right hand to be able to see where the omentum attaches onto the transverse mesocolon, making sure not to injure the transverse mesocolon, again, because that's most likely going to stay in the patient if this is a colon lengthening procedure. So here you see the lesser sac widely opened, and we're marching along the omentum below the gastroepiploic vessels as we head towards the spleen. A mistake that can be done as you're becoming more on the left side is to stay below the gastroepiploics and head towards the inferior pole of the spleen, taking the short gastrix, which is not the intention of this portion of the operation. So as the space between the stomach and the colon splays out, it's important to stay just at the junction of the transverse mesocolon and the omentum. So here you see the last bite we took was a little bit too cephalad, and we're correcting ourselves going here, just where the mesentery attaches to the omentum. So once we reach this point and it gets a little difficult, we do what we can and we stop. So again, injury to the posterior gastric wall, injuring the transverse colon mesentery as we're taking bites of the omentum and getting lost and ending up at the splenic hilum. These are the pitfalls. The other way to do the antegrade transverse colon mobilization is to detach the omentum from the transverse colon. And for this, it's the same right lower quadrant port and a right upper quadrant port, but an assistant port is required for this procedure because both the colon and the omentum are floppy. So here is a left lower quadrant port being placed. And at first, the surgeon will use the right hand to hold the transverse colon at its midpoint and the omentum lifted up. With blunt dissection, a window can be created just beneath the omentum and the where it attached to the transverse colon. Here, the mesentery and the colon are being pulled caudad. And then the assistant hand needs to come in to retract the transverse colon out of the way because both the omentum and the colon are floppy. And once we proceed a little bit closer towards the spleen, again, the lesser sac opens up and is wider and it becomes easier, and it really becomes a synchronized dance where the surgeon takes a bite, replaces their left hand, and then the assistant can replace their right hand, making it more efficient dissection. And in a minute, I think it'll become a little bit more efficient here. Again, here you're staying right along the colon, and the transverse colon, transverse mesocolon is flipped downward underneath the colon. Careful not to injure the colon because we're quite close to this colon that for colon lengthening procedure, again, is going to be staying in the patient. So here, I think, is where there's a little eureka where we get in. And you see the lesser sac clearly. And again, this is what trainees that I've encountered are more familiar with from open procedures, but I like teaching both options. As we head towards the splenic flexure again, go until it's easy, and then we'll put both areas of dissection, the retrograde and the antegrade, together just above the colon in the splenic flexure. So here we are getting pretty close to the splenic flexure. This flexure is a little bit more mobile, so we'll be able to do a little bit more from the antegrade position. Again, a combination of sharp and blunt dissection with traction by the assistant on the transverse colon. So these are the final gastrocolic attachments and then the splenocolic attachments that will be transected. Okay. So careful not to injure the transverse colon wall or its mesentery. So the third portion, this is where you put it all together, where you make the two ends join. And it can be broken down into two parts, which is completing the two areas of dissection, finishing up that gastrocolic ligament where it's tough, and finishing the cephalad-most lateral attachments of the descending colon, just coming to the spleen. Once that's done, we really meet at the spleen and make sure that all the ligaments attaching the colon to the spleen and pancreas are removed. So these are done sequentially, going back and forth, and that's what we'll look at now. So with the left hand, the colon is flipped over to access the uppermost portion of the dissection at the splenic hilum, and then the right hand of the surgeon will come over the colon and grab those last attachments and dissect them and transect them. And this I really prefer to do with an energy source if that's what I'm using for the operation, because this portion can be a little bit more bloody. And then we flip back. It's a flipping back and forth to reach those attachments, coming from the antegrade position above the colon, identifying the plane just above the colon, between the colon and the spleen. Again, using energy source makes it a bit easier and faster, but definitely can be done with electrocautery. And those final attachments are being taken. Now, another important thing is mobilizing the transverse colon mesentery at the level of the pancreas to get extra length, and we'll be showing that shortly. Usually when this portion is done, people I'm operating with feel like the splenic flexure has been mobilized. However, until these attachments just below the pancreas are taken, you don't get your bang for your buck for all the mobilization that you've performed. So identifying the avascular tissue that's holding the remainder of the splenic flexure up just beneath the pancreas and ligating that. And this can certainly be done with electrocautery or scissors because it's truly avascular. One has to just be careful not to get into any vessels because they can retract and go right underneath the pancreas at this level. And again, the colon here, as you see, is being flipped and being brought to the middle of the abdomen. Here you see the inferior border of the pancreas, and this can usually be scored. I like to score it with a hook, identify the avascular plane, and then this can be transected. And it's amazing how much more length you can get once you've done this portion. So the goal, once you've finished the supracolic meeting and joining of the planes, is you should be able to see the pancreas, the kidney, and the spleen, and you don't see the colon in this quadrant anymore. So you're chomping at it from both sides, and the splenic flexure is completely mobilized out of the left upper quadrant. So here is where you can really injure the spleen because you're reaching up to the uppermost part of the splenic flexure. Can injure the inferior pole of the spleen or the colon from retraction. And again, small vessels can retract under the pancreas, so we have to be careful. Lastly, ligation of the inferior mesenteric vein. I routinely usually do it with splenic flexure mobilization. One study looked at how much more length after you've mobilized the splenic flexure you get from ligating the inferior mesenteric vein. And they found at least a 5 centimeter difference. For ligation of the vein, it's important to release the duodenojejunal ligament, so these peritoneal attachments here, and to ligate the inferior mesenteric vein here rather than where it's exposed here, as this will not give adequate length and is the incorrect place to ligate the vein. Avascular windows are created on both sides of the vein, and it's ligated right at the duodenum to get the maximum length. Here, careful for the duodenum, but usually you've mobilized it away. Always when you're ligating the inferior mesenteric vein or artery, to release the traction on the vessel so that once you've ligated, it doesn't retract and bleed. And finally, in rare cases where there is an arc of Riemann, it's important to identify the arc of Riemann and not mistake it for the inferior mesenteric vein. So if it looks pulsatile in an artery, stop. And if it's near the location of the inferior mesenteric vein, though rare, it is there, and it is the blood supply of the left colon in this case. So stop. All right, so these are the 4 steps. First, peeling the layers, then it's a really synchronized effort to release the transverse colon. Finally, chomping away at both ends to make the 2 lines of dissection meet and ligation of the inferior mesenteric vein. And once we're finished this retrograde to antegrade dissection, the entire transverse colon should really be in the abdominal cavity and not in the left upper quadrant. Thank you.